Hello, my name is Deborah Cohen, and I am the MAVEN volunteer moderator today for this talk on pre-diabetes by Dr. Ved Gossain. And this is sponsored by our friends at Manette Community Health Center. I'm sorry, I don't know how to pronounce that. And I'd like to tell you a little bit about Dr. Gossain. He briefly served on the faculty of St. Louis University School of Medicine in St. Louis, Missouri, after completing his fellowship at Medical College of Wisconsin. Shortly after, he moved to Michigan State University, where he rose to the rank of full professor with tenure. He served as chief of endocrinology at MSU from 1996 until his retirement in 2015. And with that, Dr. Gossain, please go ahead and start.
Thank you very much, Dr. Cohen, and good morning or good afternoon to you, depending on where you are. It's my pleasure to be able to address this, what appears to have become my favorite topic, pre-diabetes. And somehow I miss the personal contact, but I think these days with technology, the Zoom will have to do, and we can reach more people that way rather than person to person. So here is the disclosure statement designed and made up by MAVEN Project, and basically saying that we don't have any disclosures to reveal. And Dr. Deborah Cohen has already said to you that this is accredited for CME credit. So this is the reason we are talking about prediabetes today. Despite strong evidence and national policy supporting type 2 diabetes prevention, little is known about type 2 diabetes prevention in primary care setting. And I'll have to speak a little bit more about this survey in a few minutes from which this quotation comes. So the objectives are to define prediabetes and diabetes. We'll discuss the relationship of prediabetes and cardiovascular complications, discuss the rationale for intervention of prediabetes, and then discuss strategies to prevent it. When you get to my age, historical facts become an interesting facts also. So some of you may not know that prior to 1979, there was no consensus about the diagnosis of diabetes. If you went to Ann Arbor, University of Michigan, the criteria that were used by Dr. Kahn and Dr. Fyans were used. And then if you went to Washington, D.C., different set of criteria were used. I practiced about 65 miles away from Ann Arbor, and this was always an interesting thing to deal with about what the diagnosis criteria were. The current criteria that we have were developed in 1997. And these are the criteria which I think most people are familiar with. A normal plasma glucose in the fasting state should be less than 100 milligrams per deciliter. If you do a 2-hour glucose tolerance test, and let me add that for most clinical purposes, except with the exception of pregnancy, there's hardly ever a need to do a glucose tolerance test. I've done a lot of them in my career, but that's mainly for research. And the diagnosis of diabetes is made if the fasting blood glucose is 126 or higher. And again, if you do a glucose tolerance test, a glucose value at 2 hours of more than 200 milligrams per deciliter, and a hemoglobin A1C of more than 6.5. And between those two extremes lies prediabetes. A fasting plasma glucose of 100 to 125, which we still do, and in the old days was called impaired fasting plasma glucose. And a 2-hour glucose value between 140 and 199 is called impaired glucose tolerance, and a hemoglobin A1C of 5.7 to 6.4. So any of these criteria, if present, would make a diagnosis of prediabetes. So it is an intermediate stage of glucose dysregulation that may precede type 2 diabetes. And prediabetes is characterized by hyperglycemia, which is defined by blood glucose that are higher than normal, but below the levels that we use for clinical diagnosis of diabetes. Just to point out that these criteria are not universally accepted, I've given you the ADA criteria already, the American Diabetes Association criteria, but the World Health Organization uses 110 to 125 for impaired fasting glucose and a hemoglobin A1C of 6 instead of 5.7 for making a diagnosis of prediabetes. But we in this country use the American Diabetes Association criteria, so you don't have to remember what the others do outside of US. It's a highly prevalent disease, and in worldwide, there are like 540 million people with diabetes and 720 million people with prediabetes. And by 2045, the number of people with prediabetes is expected to rise to 1 billion with a B. In the US, close to 38 million people have diabetes, and 96 million people have prediabetes, and many of them actually do not know that they have prediabetes. Before we started this, Dr. Cohen and I were having a discussion about the prevalence of prediabetes in youth. And all I can tell you, which is somewhat discouraging news, that overall prevalence of prediabetes in the youth, mean age of 15.5, increased by 11.6% and 28% between the years of 2015 to 2018. And maybe during the discussion section, Dr. Cohen can add up some things about the prevalence and management of prediabetes in the youth, but I'm not going to say much more about that. And it's an expensive disease, again, costing more than $300 billion. Some of that's direct cost and some of that's indirect cost. So here is the National Survey of Primary Care Physicians that I referred to earlier. It was a survey done, about 300 physicians participated. Only 50% of primary care physicians were able to correctly identify the criteria for making a diagnosis of diabetes. Only 42% correctly identified the criteria for making a diagnosis of prediabetes, the criteria that we just discussed. And only about a third correctly identify the hemoglobin A1C criteria, and only 36% of physicians referred patients for diabetes prevention lifestyle change program as the initial management approach, and only 43% discussed starting metformin. So the authors of this article concluded that there are gaps in the primary care physician's knowledge, which may improve. Addressing those gaps may improve the identification and management of people with prediabetes, but in addition, the system level changes are necessary. So by attending conferences like this, we hope to address the knowledge gap in primary care physicians with prediabetes. So now that we know the criteria of diagnosis and prediabetes, let me present to you a case. And Mr. J is a 45-year-old male of East Indian descent who comes to your office for consultation because his brother was recently diagnosed to have diabetes. And he wants to know that he has diabetes or not. He's asymptomatic, 5'10" inches tall, and weighs 180 pounds with a BMI of 26.1. Pulse is 66, blood pressure is 135/90, and the remainder of the exam is within normal limits. So hemoglobin A1C is obtained in the clinic point of care method and was 6%. And therefore, you'll now inform him that he has prediabetes and he should begin treatment, or you will advise that a test for diabetes, either fasting glucose or glucose tolerance test, or a repeat hemoglobin should be done to establish the diagnosis. Dr. Cohen, I had asked Kristen to set up this as a audience poll. I don't know if we have it or we don't. Looks like we don't.
Let's see. Okay. Let me take a look. Yes, it looks like we do have a poll. Let's see if I can. Is that your poll?
No, that's the chest pain evaluation.
Sorry, that is not the poll.
That must have been your slide, Dr. Cohen.
No, and I was not informed that we had any polls today, so I'm sorry about that.
No problem. So we can take this one off. And So we don't have a poll, but we can probably address that in the later part of this presentation. So I told you that the diagnosis criteria that we use currently were established in 1997, and they were primarily based on epidemiological data. And this is a study of looking at prevalence of retinopathy amongst Pima Indians. And if you look at the fasting plasma glucose, somewhere around 100, 105, the curve for the prevalence of retinopathy, and the retinopathy was considered to be a specific marker for the presence of diabetes. It goes up. If you look at the 2-hour fast plasma glucose with the glucose tolerance test, same sort of thing happens, somewhere around 140, 136 in this diagram, the levels go up. And same thing goes for hemoglobin A1C, somewhere between 5.7 and 6 in this slide, the curve shifts up. So having thought that the retinopathy was the marker for the diagnosis of diabetes, the National Diabetes Data Group, in consensus with the international group, established the current criteria. And similar findings were found in the study with Egyptians and NHANES. So the question that I have is prediabetes associated with micro and macrovascular complications or not? And the answer to that question is yes. And that's based on these 3 studies: the Australian Blue Mountain study, obesity and lifestyle study in Australia, and the multi-ethnic study in the US. And you can see there are a fairly large number of patients included in this. The Australian studies are predominantly white, whereas the US study is multi-ethnic. And the prevalence of diabetes is given here at the bottom in these 3 different studies. But for today's discussion, the important thing is this: the prevalence of any retinopathy in the fasting plasma glucose, 7 millimoles translates into 126 milligrams, which is where we make a diagnosis of diabetes. And as you can see, even before the diagnosis by fasting blood glucose, there is already presence of retinopathy of some type and a moderate retinopathy. And then as the glucose levels go up, the prevalence of retinopathy goes up. And the same sort of thing happens when you look at the hemoglobin A1C criteria, somewhere around here, 5.6 to 6, 5.7 to 6.4 is the diagnosis for prediabetes. And again, there are several patients who have retinopathy already with much lower hemoglobin A1C levels. So when you look at this combined, if you look at the visual inspection, there's no clear threshold, at least in the multi-ethnic study of atherosclerosis, where the retinopathy takes off. More or less, it's a continuum. And if we look at the fasting plasma glucose of 126 and look at the proportion of patients who have retinopathy, it varies from 7 to 13%. So the criteria by which the diagnosis of diabetes was made epidemiologically doesn't quite hold up if you look at the retinopathy study. And if you look at the diabetes prevention program, again, there are patients who have altered creatinine clearance at the baseline study, and then follow-up study, again, the prevalence of retinopathy goes up in patients who have prediabetes. So if we look at this sort of cumulatively, there's already 7.9% prevalence of diabetic retinopathy in the diabetes prevention program. There was 7.5 to 16% peripheral neuropathy, and 9.7 had chronic kidney disease. So this pretty much establishes the fact that prediabetes is accompanied by microvascular complications of diabetes. And this is an old study going back almost 25 years of the relationship of coronary artery disease and atherosclerotic complications in patients with impaired fasting glucose or impaired glucose tolerance. And as you can see, there is a significant increase in the presence of cardiovascular disease in patients who have either impaired fasting glucose or impaired glucose tolerance test. And this is a recent study that patients who have prediabetes, their risk for myocardial infarction is increased by 25%. If we now finally look at an umbrella review of all the studies of prediabetes, whether you use the impaired fasting glucose criteria, impaired glucose tolerance criteria, or a combination, or a hemoglobin A1C, there's something like 95 meta-analysis, which shows that with prediabetes, there is an increased risk of all-cause mortality, increased cardiovascular disease, chronic disease, and several cancers. And here are the numbers which reflect the increase of mortality, cardiovascular events, and cancer. Uh-oh, something happened, Dr. Cohn. We are having technical difficulties.
Are you not able to advance?
Something happened. Let me see. Oh, I think I must have clicked on the link. I'm sorry.
Okay, there you go.
Yeah. So if you look at the natural history of prediabetes and diabetes, you start out with people who have no change or no impairment of their glucose tolerance. Then we go through a phase of prediabetes associated period, which was variable. And then finally, most people who have prediabetes end up with type 2 diabetes. And here are the studies that have looked at the progression of prediabetes to diabetes. Pima Indians have one of the highest prevalence of diabetes amongst various groups. It's a study of 5,000 patients followed for 5 years. If you start out with normal glucose tolerance, in 5 years, only 3.6% people convert to diabetes. If you have impaired fasting glucose, 31% will progress to diabetes. If you have impaired glucose tolerance, almost 20% will progress to diabetes. And if there's a combination, then 40% of patients will progress to diabetes. And the same thing is confirmed by the other studies. And so the point is that at the baseline, if you have impaired fasting glucose, impaired glucose tolerance, or prediabetes, there's a significant risk of progression to diabetes. And a few years ago, my colleague and I, we calculated the prevalence progression of prediabetes to diabetes was about 5% per year. In some randomized controlled trial, it varies from 5% to 18.3%, and 70% of individuals with prediabetes may eventually develop diabetes. On the other hand, if you're older, there are many problems of being older, but one of the things that happens is that the progression of prediabetes to diabetes is slowed. So this is a Swedish study, 12-year follow-up. Most of the older adults with prediabetes remained stable, 42%, or reverted to normal glycemia. But all that's not good news because 1/3 of them developed diabetes or died. And in the atherosclerosis risk in community studies, these are patients who are 60 to 90 years old. And again, in this study, older individuals with prediabetes remained at lower mortality risk over a median follow-up period of 5.6 years. And of course, patients who had diabetes, they had a substantial and an independent effect on short-term mortality. So altogether, if you look at the meta-analysis, 12,000 subjects, in 5 years, some 34% patients may actually revert back to normal. In 10 years, 42%, but if the follow-up is longer, then the reversion of going back to normal is lower. So the rate of resolution decreases with longer follow-ups of these patients. So the next question is, should we screen for diabetes? We should always be screening for diabetes. I'm sorry, I misspoke. The question is, should we screen for prediabetes? And the answer to that is yes, because prediabetes is associated with increased cardiovascular risk, and therefore screening for and treatment of modifiable risk factors for cardiovascular disease is suggested. So these are the criteria for screening for diabetes that you should be familiar with. If people are overweight, if you have a first-degree relative with diabetes, high-risk ethnicity, and that includes everybody except white people, history of cardiovascular disease, including hypertension, high cholesterol, And if you have prediabetes, the recommendation is to screen them every year, whereas for all the others, if you do a screening and that's negative, they should be screened at age 35. And this is a slight change. It used to be 45 years old, but now they've changed it. The screening should begin at age 35 if you have any of these risk factors. And the U.S. Preventive Task Force confirms that screening for prediabetes is of moderate benefit, and they conclude with moderate certainty that screening for prediabetes and type 2 diabetes, offering or referring patients with prediabetes to effective preventive treatment has a moderate benefit. So the takeaway message is clinicians should offer or refer patients with prediabetes to effective treatment interventions. So the next question is, can we prevent the progression of prediabetes to diabetes? And again, the answer to that question is yes. And there are several studies which have looked at the lifestyle intervention and the effect on progression of prediabetes to diabetes. And then we're not going to have time to go through all the studies, but I will discuss briefly the diabetes prevention trial and the Indian study of lifestyle modification for prevention of prediabetes progression to diabetes. There are several studies that have looked at drugs, starting with metformin, which was part of the diabetes prevention program. The Indian study also looked at metformin, and they looked at a combination of metformin and lifestyle. And again, there are many drugs which actually have a higher rate of prevention of prediabetes to diabetes than the diabetes prevention program. But question that, okay, let's discuss this, and I'll come back to that. So the diabetes prevention program was 3,000 patients roughly. They were randomized to either intensive lifestyle modification or metformin or placebo. And after about 4 years of follow-up, patients who were randomized to lifestyle modification lost a significant amount of weight. This is approximately 7%. And there was a 58% risk reduction compared to placebo with those who were randomized to lifestyle modification. And the lifestyle modification basically consisted of 150 minutes of exercise per week. And they were helped by repeated reminders to continue with that lifestyle modification. And in this metformin study, there was also a 31% risk reduction compared to the placebo effect. We already alluded to the fact that patients who are older than age 60, the rate of progression from prediabetes to diabetes is slower than in the younger population. And in this particular diabetes prevention study, the benefit of lifestyle modification was also greatest in the older age group, 71% compared to 48% in the younger age group. And the only reason I wanted to refer to this Indian diabetes prevention program study is because when they combined lifestyle modification with metformin, they did not notice any significant effect compared to metformin alone or lifestyle modification alone. And those patients who were followed up for a longer period of time, again, the patients who were randomized to lifestyle modification, the cumulative risk of developing diabetes was significantly lower compared to the group with metformin or with the placebo group. So to summarize, a weight loss of 7% by walking about 150 minutes per week reduces the risk by 58%. And certain drugs, which I alluded to earlier, their risk reduction may be actually higher than the lifestyle modification. So in recent studies, vitamin D supplement, must be a slide that missed out. So in recent studies, vitamin D supplementation and use of GLP analog semaglutide have also been shown to reduce the progression of prediabetes to diabetes. So since several drugs have been used for reduction or progression of prediabetes to diabetes, the question we have for you is, which of these following drugs is approved for use in prediabetes to prevent its progression to diabetes? And again, we don't have a poll, so I'll give you the answer. The answer is presently no pharmacological agents are currently approved by the FDA for management of prediabetes, although there are many drugs, like I showed you, that reduce this risk. So the consensus statement from American Association of Clinical Endocrinologists is that untreated individuals with prediabetes are at increased risk for diabetes, as well as for micro and macrovascular complications. And therefore, all the cardiovascular risk factors like the blood pressure, the lipids, should be managed in the same way as we manage for those patients who already have established diabetes. And like I already said to you, that the aim of the lifestyle management is to reduce the weight by 5 to 10%. It was 7% in the diabetes prevention program. And this translates into 30 to 60 minutes of active walking daily, at least 5 days a week, and some caloric restriction. Now, if those lifestyle modifications alone is not enough, then we can consider adding pharmacotherapy, although I've already mentioned to you that at the moment, none of the drugs have been approved by the FDA. Having said this, the American Diabetes Association recommends that metformin therapy for prevention of type 2 diabetes should be considered. They don't say use it, it should be considered for those with prediabetes, especially those who have a BMI of more than 35 and have age less than 60 years. And this is an A recommendation, and also for women who have prior gestational diabetes. So again, coming back to the primary care and its management of prediabetes in the primary care setting, this study, this probably was the group, same group of physicians rather. They followed 4,000 patients, and within 12 months, 63% came back, had repeat glycemic testing, but only 10% were coded as having prediabetes. Only 1% were referred for nutritional services. Only 5% were prescribed metformin. 6% developed diabetes within 12 months, and higher glycemic levels in BMI of more than 30, and Black individuals had a higher risk of developing diabetes. So the conclusion is that the rates of prediabetes clinical activities are low in primary care, and therefore strategies are urgently needed to improve prediabetes care, thereby preventing or delaying the incident diabetes. So let's come back to our patient. And this was a 45-year-old male who came to see you because his brother was known to have diabetes. His physical exam was, as mentioned above. And so hemoglobin A1C was obtained in the clinic, and it was 6%. So although 6% is consistent with making a diagnosis of diabetes, but that's not based on hemoglobin A1C measured by the point of care. This hemoglobin A1C level of 5.7 to 6.4 for making a diagnosis of prediabetes should be done in a standardized laboratory, which uses the DCCT, Diabetes Control and Complication Trial standards. So that would be premature to tell him that he has prediabetes. Therefore, the option B is the correct option, that we should do another test. And you can pick any test you want, fasting glucose tolerance test, or a repeat hemoglobin A1C. And in practical terms, if the patient is in the clinic with you, probably a repeat hemoglobin A1C would be selected because it's easier. The patient is not fasting and doesn't have to. And glucose tolerance test, as I mentioned earlier, is probably not needed for clinical purposes, although you may do it for other reasons. So a fasting plasma glucose was 105. So that now confirms that he has prediabetes. Therefore, you would begin lifestyle modification, that is diet plus exercise, to lose weight. Whether or not you begin metformin, it still remains debatable in my mind, because according to the ADA criteria, he's less than 60, so one could use that, but his BMI is not higher than 35 or not 35 or higher, so he doesn't quite meet that criteria. And the argument for not using metformin is, why give him metformin, which is a recommended treatment for diabetes, before he develops diabetes? But again, as I've showed you, it can also be preventive. So this would where I would think a clinical judgment and shared decision-making with the patient will come into consideration. And based on that, one could either prescribe or not prescribe metformin. So the take-home message is, we need to focus. We need to shift our focus from managing diabetes to pre-diabetes. Lifestyle modification, everybody should be doing that. Everyone should have lifestyle changes, follow a healthy diet. Everybody should be doing at least 150 minutes of exercise each week to prevent the risk of cardiovascular complications, including heart attacks. And this is a very nice article in the JAMA. It's too complicated, too busy a slide, and I'm not going to go through it, but this is a really nice article. It talks about the risk factors for prediabetes, screening, criteria for screening, and treatment. So this is in your slide, and the references here. You can probably go home at your leisure and go through this article. With that, I'll stop, and I'd be happy to answer any questions if there are any, and I hope there are a few. Thank you very much.
Oh, thank you, Dr. Gossain. And yes, we do have some questions. So let me, okay, Liliana, I've unmuted you. Wait, I think. Yes, can you talk now? Nope, doesn't look like she can.
Her microphone's still looking like it's muted, so I don't know.
Okay, I'm
Can
trying
you
to.
hear me?
Yeah.
Yeah.
Can you hear me?
Yes, we can hear you.
Okay, I just wanted to ask that in the clinic that we work at, we normally start metformin when the A1C is 6. So they're pre-diabetic, and the idea is to get them to make lifestyle changes, but we also start the metformin 500 milligrams just once a day. But we don't do that if it's 5.9 or lower. And I just wanted to see what your thoughts are in light of your statements that you've made today.
Well, it depends. Like I showed you, the American Diabetes Association makes a diagnosis of prediabetes with a hemoglobin of 5.7. And the rest of the world makes a diagnosis of prediabetes based on a hemoglobin A1C 6 to 6.4. And so I think that the lifestyle modification should be used for everybody who has a hemoglobin of 5.7 or higher. As a matter of fact, like I said, everybody who's healthy should be using these lifestyle modification in methods like walking, 30 minutes a day for 5 days a week, following a healthy diet. So I'm not sure that 5.9 versus 6 or 5.7 versus 5.9 makes any difference. I'm personally not in favor of using metformin unless the lifestyle modification is not working or people are not able to do it. One of the problems with lifestyle modification is most people are not able to adhere to this. And then, as I showed you in the Indian diabetes prevention program, adding metformin to the lifestyle modification did not have any additional effect. So if you use that study as a reference, then probably metformin is not great. Having said that, metformin is a relatively safe drug. We've had it for a very long time. And as I showed you, the ADA recommendations are, it should be considered. They don't quite come out and say it should be ordered or prescribed. But so this is where you will probably have to talk to the patient, emphasize the lifestyle modification, and then if you feel that something else needs to be done, metformin is not a bad choice. I don't know if I answered your question or went around in circles, but that's the situation with metformin in prediabetes.
No, you did. It's just that some providers, there's like a constant debate at the clinic, and some argue exactly what you're proposing. And then others, because we're more holistic, but then there's other people that want to go straight to metformin. So I'm glad that I was on the right track doing it the way you do it.
But some people think that both the patients and the physicians think that now that I prescribed a drug for a particular disease, it's going to take care of it. And the problem with metformin in pre-diabetes setting is it's not going to take care of it. You got to still continue to do the lifestyle modification. And then on top of it, if you think metformin will help, then we can add the metformin to it.
Okay.
Okay.
Thank you so much.
You're welcome.
Thank you. We do have some more questions. One is, what role does fasting insulin have? Obtaining a fasting insulin level.
Yeah, well, it depends on the patients. So for example, obese patients, you expect that the fasting insulin levels will be higher. But in terms of making a diagnosis of prediabetes, the fasting insulin or C-peptide levels really have no role. The criteria are based, as we talked about, on fasting glucose or hemoglobin A1C or glucose tolerance. So, if you're curious what the fasting insulin levels are, you can get it done, but it's not going to help anything. So I don't think it's indicated.
Okay, thank you. Another question is, for the lifestyle modifications, was the low calorie, low fat diet low carb?
Well, there have been a number of studies looking at the effect of these diets in obesity and the weight loss. Low carb, low fat, high protein diets. And the bottom line is that the macronutrients don't make a big difference. What the difference happens is, what's the caloric intake? As long as the caloric intake is reduced from what is required to maintain that weight, you will get a weight loss. It doesn't matter whether you are a low carbohydrate diet or a low fat diet. The carbohydrates kind of get a bad rap, but basically, about 45-50% carbohydrates, adequate amounts of protein, and limited fats, particularly the saturated fats, constitutes a healthy diet, and that's what we should prescribe with caloric restriction, and that should have the effect of desired weight loss.
Great, thank you.
Along with the lifestyle interventions.
Right. A related question is, does intermittent fasting have any role in prediabetes in patients with normal weight?
I think most of the studies that I'm aware of have used intermittent fasting, and they work in terms of people getting to lose weight. But if you have a person who's got normal weight and they happen to have prediabetes, then I think the lifestyle interventions that we talked about have a bigger role. And then you don't want them to intermittent fasting or other. If you don't need for them to lose weight, then there's no point about intermittent fasting or any other maneuver to try and get them to lose weight. But most people who have prediabetes, and particularly those who have diabetes, tend to be overweight and quite obese.
Right. I have a question. I'm wondering if the main mechanism by which metformin has an effect really is in those who lose weight. If they don't lose any weight at all, are they in the category of people who still have prevention of progression from prediabetes to diabetes?
Well, metformin is a relatively what's the word I'm looking for? It's not very effective in terms of causing weight loss, although most people who take metformin lose some amount of weight. And then, certainly the weight loss has an effect on prediabetes progression to diabetes. And that's where the GLP-1 analogs that I kind of alluded to have come in. The GLP-1 analogs have been shown to delay the progression of prediabetes to diabetes. And most of that is because of the weight loss, but they figured out that over and above the weight loss, there is some effect of these GLP-1 analogs in terms of causing delay of progression to prediabetes to diabetes. So metformin may be helpful in terms of a little bit of weight loss, but it's not a very effective weight loss drug. I don't know if that answers your questions.
It does. It does. Thank you. we certainly have time for more questions. Anyone else like to pose something in the Q&A or the chat? Well, we have Dr. Gossain here. Thank you. That was very good talk, and someone commends you on the insight and data-driven information. So thank you very much.
Thank you.
Any other questions? I'm not seeing any others. Do you start these patients on statins?
Again, if they have indication for statins based on their lipid profile, based on their cardiovascular risk profile, yes, but to the best of my knowledge, I think there's no indication for starting statins specifically only for prediabetes progression to diabetes, although statins are multipotent, they have a lot of effects. So, but there are no studies that I know of that have looked at the effect of statin on progression of prediabetes to diabetes.
Does weight training help prevent diabetes?
Weight trainings improve the muscle mass or muscle strength. I'm assuming that that's what the person who's asking the question is referring to. I think most of the studies that have looked at the effect of weight, they just talk about the weight, but the muscle strengthening or that kind of an exercise preventing diabetes, again, I'm not aware of. Are you, Dr. Cohen?
No, I'm not just strength training alone.
Yeah.
Any role of Jardiance for pre-diabetes?
Well, again, none of these drugs are approved for use of prediabetes, and the only one that has been studied to some extent is metformin, and now recently the GLP-1 analogs. So that's probably the answer to that question.
Okay. I think I've covered most of the questions that we have here. Anything else that people would like to address? While I'm waiting, I just want to remind you that if any of you are joining from different clinics than the Anchor Clinic in Massachusetts here, please know that if you have any lectures that you'd like to request, MAVEN is very happy to accommodate you. And I'm not seeing any further questions, so I think we'll give you a few more.
So Kristen and Dr. Einstein had said, do not go overtime, leave some time. So I've left enough time. And now that we have actually a few more minutes, I'm going to quote a colleague of mine. I've given you back 15 minutes of your life. Enjoy it. Thank you very much.
Very good. Thank you all.
Thank you. Bye-bye.
Okay. Bye-bye.
So did it go all right, Dr. Cohen?
Yeah, I think it went really well. I'm sorry about the polling. What I wanted to do.
Maybe that polling would have taken up another 5 or 10 minutes. I don't know, but.
Yeah, let me go back and look at the polls, polls and quizzes. So I can go back. Kristen has to load them in each time, and it looks like what she has here are from other talks. So let me just see. Yeah, everything is from a previous cardiac talk. So did you talk to her?
I think we had it once. I've given this talk once before.
Okay.
For another clinic, and at that time it was too early or whatever. There was not even a CME talk at that point, but we had the poll in that section.
I think you have to ask her each time, and then she loads them in and lets us know, and then they'll be visible. But I think what's visible now is just from the previous talk that used poll.
No, I did not ask her to reload it. I didn't know that I was supposed to. So.
All right. Well, next time.
Next time. Yeah.
I thought that was really great, and it's interesting because in the pediatric population, we don't have the data that you have in the adult population for how to proceed with cases like this. And so I think we're more aggressive with the kids who have more risk factors, especially family history. Maybe they have dyslipidemia, maybe they have early liver disease, maybe they have high blood pressure, but we don't see that much morbidity in these kids early on, so it's hard to know. It's hard to know at times what to do with them, but I think because they often have such an aggressive type 2 when they do get it, that we're probably more likely to start metformin on some of those kids anyway. So
Again, I don't know. I'm sort of relatively new to MAVEN. There was a webinar that was held by, and somebody sort of made a presentation, what kind of presentation to make to the clinics that we are now addressing to. And the takeaway message for me was they don't want to look at the detailed studies that came to the conclusions. Right. You want to give them the conclusion. So specifically, I took out the GLP-1 study and the vitamin D study because they said they don't care about the studies. They want to know what the bottom line is.
That's right. I think you want the practical points. Right. And it was very, very, very good for that. So I think you did a great job. And I'll let Kristen know that next time you're going to give it, she should ask you about the polling.
Okay. All right. Thank you.
Have a good day.
Pleasure meeting you virtually.
Nice to meet you too.
Right.
Okay.
Bye-bye.
Bye-bye.